Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Well, welcome everyone. I'm Brigid Maloney.
And I'm obstetrician Dr Patrick Maloney.
And now I've sat behind the mic this year, but it's your first time back, Pat, isn't it?
I know, it's good.
Yeah, you're here.
I'm ready to go. We've got Q&As today, which you know I like.
Yes.
And it's great that people have come to us through the speak pipe so we can hear their voice, which is so nice.
And actually we've got so many of them because we missed our December Q&A.
Good.
That we're going to do back-to-back Q&As.
Let's get into it.
And also it's because, I don't want people to wait too long to have an answer to their question. So,
sure.
Yeah. So we're starting from first, if that makes sense.
Perfect.
Good. Let's hear from our first caller.
Hi guys, my name is Pia. I've just started listening to your podcast and I'm really enjoying how much I'm learning. I'm about to start trying for my first baby, but I do have a previous heart condition. I had an aortic coarctation that was repaired when I was a baby, and thankfully the resulting minor heart damage doesn't really impact my daily life. However, I have been told there's a chance it could affect me during pregnancy, particularly with potential high blood pressure. So I just have 2 questions that I'd love to hear your thoughts on. The first one is, how much overlap or communication is there between an obstetrician and another specialist like a cardiologist in a pregnancy with hopefully minor cardiac concerns? I plan to go with a private obstetrician and I'm booked in to see a cardiologist who specialises in cardiac obstetrics. And what considerations would you take into account during pregnancy with someone with cardiac concerns, and especially during labour and delivery? Thanks.
Now, I didn't catch what she said. What was her heart complication that she said?
It's something called coarctation of the aorta, which is a narrowing of the aorta that we sometimes see in babies. Ideally picked up by the paediatricians in the first examinations and managed surgically. Yeah. So it's a terrific question and a really interesting one. There are lots of people out there who have congenital heart disease, so problems with the structure of the heart, who once upon a time may not have survived as infants or may not have survived to adulthood, who of course now do because of advances in paediatric cardiac surgery. So those people who are women will grow up to survive into their reproductive years, whereas they once would not have. So there's lots of people with corrected congenital heart disease who are having a baby. And the caller's quite right. We use a liaison between obstetrics and the cardiologists to sort out exactly what the condition is, exactly what repair has been done in the past, exactly what the woman's current functional status is. Is she short of breath half the time and quite limited in what she can do, or is she perfectly fine? Mm-hmm. And then make a plan to assist with the management of the pregnancy, taking into consideration the significant physiological changes that happen in a pregnancy and the additional strain that the pregnancy itself or certainly labour might put on that woman's heart. Mm. So I use a terrific clinic in Melbourne where my cardiac patients are already usually enrolled in, which is a special clinic for adults who are living with congenital heart disease. And they have people there who are experts for when those people enter a pregnancy.
One of her questions was how well does an obstetrician and another specialist like a cardiologist work together? Mm. And I know from being in the clinic that if that another specialist is required during a pregnancy, you work quite well with them. Is that normal? Like, is that...
Yeah.
Yeah, that she could expect that from her
Oh,
obstetrician?
100%, yeah. So that's normal and, in fact, required. Yeah. So it's unlikely that the obstetrician would have all the expertise necessary to give advice on that. And liaison with those other specialties is super important. What the obstetrician might know or will know is that if the cardiologists say that this person is totally fine, it's been fixed years ago, they are exactly the same as someone who was born with a totally normal heart, obstetrician goes, fantastic. If they say this person is fine but has a limited exercise tolerance and may not go so well in labour, then the obstetrician will say, fine, thank you for that. Let's make an obstetric plan that takes that into consideration. So for some people, we might recommend birth by planned caesarean section. For other people, we might recommend a labour's fine but not a prolonged pushing phase. So that could look something like a planned epidural, labour naturally and get to fully dilated, and then have a planned instrumental birth so you don't have to push. And then, as I said, some of them, there are no limitations recommended by the cardiologist, in which case it just manage as per usual.
And roughly how many times would she see the cardiologist during the pregnancy?
Oh, a few. So they tend to keep checking on how the woman's going, and typically those visits include echocardiograms, so that they've got right up to date information, perhaps 2 or 3 times in the pregnancy, on how the heart is coping. So that's and then at the same time, they would advise, see, some of these are run in families, and so we would be doing extra ultrasounds on the heart of the fetus, and not just the usual one that everyone gets at 20 weeks, but some extra ones where some very clever people called fetal cardiologists get involved, do the ultrasounds, check out the structure of the fetal heart, and if a problem is identified, then they would also be giving advice to the obstetrician to say, look, this baby's going to come out with some issues. Are you sure you've got this woman booked in the right hospital? Should she be delivering in a capital city? Should she be delivering in the obstetric ward that's right next door to the big cardiac hospital for babies? And we would make appropriate plans for that. Yeah.
So, Pia, it sounds like extra tests for you, but our hope is that those tests just sort of monitor you and your pregnancy and birth go along really well and nicely.
Yeah, this is one of those situations in obstetrics where to get good outcomes, there's a fair bit of planning that we need to do, and anticipation of potential problems that can be managed in advance of them happening.
Yeah. Good luck.
Out Louders, hey, it's Mia, and I have news for 2026. I'm back on Out Loud. My long service leave is over and I am back in your ears because I've missed you. I'm going to be doing subscriber episodes twice a week, all year, so if you've missed my voice and my chaos and the way I say premiere, subscribe to Mamma Mia via the link in the show notes if you're not already a subscriber, while I go and make myself a giant bucket of tea and find an outfit that Jessie will hate. I'm excited. Let's go.
Let's move on to our next caller, Pat. She's put 2 in because she forgot to ask a question. So
Easy.
I might play them perhaps together. So here's her first question.
Hi, thank you so much for taking my question. I've had a really tough year and I'm just hoping you can help me make sense of what's going on. I'm turning 31 in December and my first pregnancy was when I was 28. I fell pregnant on the first try back then. My cycles have always been regular 28-day cycles, and that was a really easy, complication-free pregnancy. My son was born in Feb 2024 by emergency caesarean, which was due to slow dilation. I was 2 centimetres at the time of birth and fetal distress. Otherwise, everything was fine, and he was born healthy and he's going well. When my son was 15 months old, we started trying for a second baby and I fell pregnant on the second try. The NIP results was low risk, but at the 13-week scan, we found out that I had a missed miscarriage. My baby had passed away at 12 weeks and 1 day. I miscarried naturally, but then had a D&C afterwards to remove the placenta. I had blood work done after that through my GP, and the only thing that came back was a slightly positive anticardiolipin result of 24. My GP didn't seem to think that there was anything to this, but I wanted repeat bloods done. And we didn't have the baby tested. I had one period after that miscarriage and then fell pregnant again, but it ended as a chemical pregnancy at around 5 weeks, and I had bloods and HCG readings to kind of confirm that. Since then, I've given my body 2 full cycles, and I'm giving myself 1 more. My second set of bloods, which was taken the other day, still showed the same slightly positive anticardiolipin result, and I received them yesterday, so I'm very confused. I have a specialist appointment just before Christmas, which is the earliest I can get in, but emotionally this wait is so hard. We've been trying since April and now it's November, so yeah. My question basically is, what could this mean for my fertility and my future pregnancies, and how worried should I be about a borderline anticardiolipin result like this? Is this enough for APS along with my miscarriages? I've previously been told that my first miscarriage was bad luck along with my second miscarriage. Is there anything I can be doing in the meantime? Do you have any opinions on this? Thank you. Also, my name is Ruby.
So Ruby has one more follow-up, short follow-up.
And I forgot to say with my previous recording that in my first miscarriage, there was a minimal amount of subchorionic hematoma spotted, but that wasn't seen when we found out that my baby had died.
Okay, Pat, where would we like to start here?
Okay, there's a lot there. Thanks, Ruby, for getting in touch and for bravely sharing your story. That's wonderful and could be of a lot of benefit to other people. So well done for doing that. I think I'm sorry to hear about the pregnancy losses. I think that it raises a couple of interesting points, and that is that pregnancy loss is disappointing and heartbreaking for people. And sometimes one of the hardest bits of that is that we don't know exactly why it happened or exactly what is going to happen to that person in the future. And people often find that very, very frustrating. It's quite common if someone has experienced recurrent pregnancy loss to start looking for potential underlying causes for that, even though most of the time we don't find those. And most of the time what the person is experiencing, to the best of our knowledge, is a run of bad luck, and that will presumably come to an end if they can be persistent and brave enough to keep going. But each pregnancy loss, of course, is a kick in the teeth. So we certainly want people who've experienced recurrent loss to come and see us. And we've covered elsewhere that the guidelines are different.
Miscarriage guidelines.
Yeah. So that you used to really have. We used to be seeing people who'd had perhaps more miscarriages before they came to see us, and now the guidelines suggest earlier investigation. And one of the things that we've always been potentially more likely to investigate is a pregnancy loss that happens relatively late. So an 11-week loss diagnosed at 13 weeks is more significant.
I think it was even later. It was 12 weeks and 1 day.
You're right.
Said,
so,
yeah.
So that's more significant and statistically more likely to represent an underlying problem rather than just a miscarriage that could have happened to anybody, which, as we know, typically happens around the 6-week mark. So a bunch of tests get done. And one of those is a bunch of blood tests called a thrombophilia screen, where we're looking essentially at abnormal blood clotting behaviour. Ruby had an anticardiolipin test that was weekly positive, and that is one of those markers that's associated with potentially with recurrent pregnancy loss. So, without getting too much into the details, this is somebody that we would want to be under specialist care, because there would be some recommendations to be made either by an obstetrician skilled in recurrent pregnancy loss or in conjunction potentially with a haematologist, blood specialist, to give some very clear advice about the management of, doesn't matter which of the tests comes up abnormal. Some of them are thought to not be terribly predictive of pregnancy loss, and we might just say carry on, see us when you're pregnant. Others are a much bigger problem, much more predictive of pregnancy loss, in which case we might have that person potentially on aspirin while they were trying, changing to a strong anticoagulant like Clexane as soon as they were pregnant. And that needs a plan in advance. Yeah. But the outcomes are good, but we don't want people to have to go through a whole bunch of losses before the light comes on their head and we think, oh, perhaps you should have some Clexane.
If someone has had a miscarriage and, with Ruby, they found out at 13 weeks, is it common, and it sounds like that was managed at a GP level, is it common for that GP to order tests such as the anticardiolipin?
Potentially, if someone was had pregnancy care as part of their expertise, but the interpretation of those results and the recommendation for appropriate preventative management in an upcoming pregnancy, that seems to me much more likely to be happening at a specialist obstetrician level, plus or minus haematology. Yeah,
and her subchorionic hematoma that they found out subsequently or, talked about.
Sure.
Is that something that she should factor in the first miscarriage?
No, not really. It's unlikely to be relevant. Really, the presence of a subchorionic hematoma at the ultrasound that diagnosed the miscarriage is something we need to take notice of. But it's not clear whether that was there anyway or whether it was actually what caused the miscarriage. But it's part of the overall miscarriage picture, but probably not the most key issue on its own.
Yeah.
And unfortunately, the fact that the pregnancy passed naturally but the placenta got left behind, and surgery was still needed, that is kind of adds insult to injury, but it is very common. And it's more common the later the miscarriage occurs that the placenta won't just detach and come out.
And if she's got an increased anticardiolipin with her second miscarriage at 5 weeks, is there any correlation between those two things?
Well, potentially. So that anticardiolipin test, that doesn't go away. That's just what her body does, and so that is something that needs expert advice and management. Yeah.
So Ruby gave us this question in late November. She was having her specialist appointment in December.
Yes, hopefully they've attended to that.
Hopefully something's worked out for you, Ruby, and we'd love to hear what the result of all of that was. If you call back, that would be great.
Perfect. What we need is a plan, Ruby. So, a clear plan of whether you should be on any blood thinners now and whether you should be on any the minute you get a positive pregnancy test, and how and what doses and how much. A clear plan.
All right. Well, let's hear from an old patient of yours, Pat.
Oh, really? Good.
Yeah.
Hi, Dr. Pat and Brigid. My name is Laura and I'm currently not pregnant, but I do have a little 4-month-old that I was lucky enough to have Dr. Pat assist in her birth. I've got 2 questions surrounding C-sections. So I was recently having a conversation with someone about my birth that did end in a C-section. And the person that I was having this conversation with said to me that because I had a C-section, I would either develop endometriosis or I'll be infertile now for subsequent pregnancies. I'm just wondering how true this actually is. Thank you.
Oh my God, this makes me so cross.
A lot of false information going around, isn't there?
And guilt.
Yes.
Why do we do this to each other?
Oh, it's terrible. All right, thanks for getting in touch, Laura. I think this is a valuable one. Laura can ring me up, but
for everybody to hear. That's why I put it on.
This.
Yeah,
exactly. So look, When we have, there's a number of issues that come out of this. When we have a caesarean section, we need just to keep our focus on the fact that it's an operation that has risks, and we need to be confident, patient, doctor, that it's the right decision for that woman at that time. I like to think that in most, or if not all cases, we're doing that for the right reasons at the time, with the information we've got at the time in the circumstances that we're in. Yeah. So, for example, if we've got somebody who's, 2 centimetres in labour, the labour stalls, the labour obstructs, we try and fix that, we can't fix that. Well, caesarean section is our only real choice in that situation. I don't think there's a lot wrong with the use of caesarean section in the original decision. Flow-on effects, there are some. There isn't a connection between caesarean section and the development of endometriosis. There's a potential connection between caesarean section and the development of adenomyosis, which is a different disease. So remembering endometriosis is where tissue that looks like it should be lining the uterus crops up elsewhere in the pelvis, causing problems with pain and
other places,
fertility and other places.
Yeah, eyeballs,
and is common in teens and 20s, and is an important fertility issue. Adenomyosis is a similar but different disease where tissue that looks like it should be lining the uterus is present throughout the wall of the uterus within the uterine muscle. And it's a fertility issue for some people, although its peak incidence is later in a woman's life, so it's less likely to affect fertility in the usual fertility age group. There is some evidence that having caesarean sections might influence the development of adenomyosis. Nobody knows exactly why, but it might be that the operation itself disturbs the lining, disturbs the layers of the uterus. And as careful as we are to put the uterus back together in the right order with the layers all matching, it's not possible to do that completely precisely, and that may allow some glandular tissue to escape into the muscular layer and set up the early stages of adenomyosis.
And it's not just women who've had a caesarean who get adenomyosis.
No, not at all.
Like, you can get adenomyosis without caesarean. So.
Or without having ever been pregnant. So it's not, if it's a cause, it's not the only cause. So that connection exists. But our usual response to that is, well, that's good to know. But on the day, if we're in labour, if caesarean section is necessary for whatever reason, then we're just going to have to do the Caesar because we have to do it now. And if there's a connection to adenomyosis that cropping up in 15 years, well, so be it. It's not a reason not to do the Caesar at the time if the Caesar is required at the time. Yeah. So it's one of those good examples of obstetrics. There are decisions for today, and then there are things then there are possible flow-on consequences which can be dealt with in time.
I've had people very close to me ask, sort of say things such as the baby's development is delayed because of my caesarean sections, or I've had people say that their sense of self is different because they've had I've had a caesarean section. Yep. My answer to that now is, how did you want me to have the baby?
Yes, exactly right. Yeah, that's exactly it. So these are not helpful conversations. No. They lead people towards feelings of guilt, and there is no, as far as I can see, there is no point to these conversations because they don't do anything but make a woman who's made a well-informed, sensible decision in her personal circumstances to have her baby in that way, and it's really it's not helpful. In terms of connection between caesarean section and future fertility, I think the world record is one woman having more than a dozen Caesars. I've had patients who've had many caesarean sections. With women these days having fewer babies, it's very unusual for the caesarean section to be the reason why a woman would experience secondary infertility. Okay, so she's had a Caesar and then she's having trouble getting pregnant again. It's a thing. And sometimes we put that down to various problems related to that initial Caesar, but it doesn't mean that the decision to do the initial Caesar should be revisited. It was the right decision at the time.
Can I just clarify then? Are you saying that there is some link between caesarean section and infertility?
Potentially. So there's a condition called a caesarean scar defect, where you can have a Caesar and then the wound on the uterus doesn't heal terribly well. It forms a little internal ledge or defect where the muscular wall of the uterus is very thin at the point of the Caesar. And that can get fluid trapped in there, and that might potentially be responsible for a secondary infertility situation where the woman has trouble getting pregnant again. There's a operation that's being done a bit more often these days, where the old scar can be cut out and a nice, fresh, thick closure can be done, and that's showing some positive results. Although there's very little published data. Yeah.
And can that shelf be seen? Now, I know people are going to go, oh, my God, maybe I need to have that examined and make sure that that's not my issue.
You can see it on an ultrasound.
Ultrasound,
yeah.
Okay.
So if someone's having trouble getting pregnant after a previous pregnancy, and in particular if that previous pregnancy was by caesarean section, that's something that we would look for. Okay. But it still doesn't...
Pretty rare too, isn't it?
It's rare. It's rare-ish. But it still doesn't mean that the original baby shouldn't have been born by caesarean section. And I think that if we start trying to rewrite the past, that leads to nothing but guilt.
Yeah.
Yeah.
And one other thing that people might be sort of confusing is that if that person is older to begin with and has their first baby by caesarean.
Exactly.
They're older again when they're trying for their second.
Absolutely.
Yeah.
Everybody in the world having their second baby is older than they were when they had their first, by definition. And factors that we know influence fertility. If we look at the role of caesarean section, it's out in the small print. If we look at the role of maternal age and obesity in our community, they are the big ticket things. Yeah.
All right, Laura, I hope that answers your question and that you can sort of, put that into the basket of that you don't have to worry about for if you wanted to have your second baby.
Quick question. Are you tired of the news? Do you want a podcast that isn't self-improvement? Come get unleashed. It's funny.
I also think that underwear is sort of almost like a new marriage. Like it starts off, it gives you the best of what it offers at the beginning.
It's unhinged.
I have a bit of a thing for my friend's husband's salami.
Hello.
It's not here to teach you anything.
I need to make sure he looks at me. One side, I'm going to make a sign. This is what I married because I didn't meet you in time.
Yeah, right.
The other side, with pointing to my son who's 12. Look what we could have had, Lewis.
Yeah, I love it.
It's a good time for Gen X. So search Unleashed wherever you get your podcasts. New episodes every Tuesday.
All right, let's move on to our next caller.
Hi, Dr. Pat and Brigid. My name is Nina and I have a gorgeous 10-month-old baby boy. Firstly, thank you so much for everything you do. Your podcast was my companion during my pregnancy. I have a question. I'm wondering about the likelihood of developing granulation tissue on an episiotomy scar the second time around. For context, I had a straightforward vaginal birth with an episiotomy, no instruments, and a 3-hour labour after my waters were manually broken due to reduced fetal movements. My recovery, however, was really challenging. Granulation tissue formed on my episiotomy scar, and the first removal was done with silver nitrate without any kind of numbing at all, and only given gas at 10 weeks postpartum. It was way more painful than my birth, even though I didn't even have an epidural in birth. And a gynecologist who later performed the second removal told me that it never should have been done without any kind of numbing. Because of the whole ordeal, the public hospital has offered me a C-section next time around. I'd love to know what Dr. Pat thinks. Is choosing a C-section for this reason a valid concern going into a subsequent pregnancy? And a second question while I'm here. Would Dr. Pat recommend removing a cervical polyp before trying to conceive again? I had one removed in a pap smear before my last pregnancy, and I'm wondering if they can have any effects on conception. Thank you again for everything you do. I really appreciate the work that you guys do.
All right, two very different questions, aren't they?
Great questions.
Yeah.
The second one's easy.
Yeah.
Cervical polyps should be removed.
Right.
A tiny portion of them have cancerous or precancerous changes within them. They bleed when they get hit against by sex. They should be removed.
And is that a day case surgery, or how do they get removed?
It can often be done as a rooms case if it's small.
Yeah,
you just
right.
grab the polyp and twist it, and the stalk breaks. Big ones or ones that seem to arise from up the cervical canal where you can't see where the stalk comes from are best done in hospital under an anaesthetic. But cervical polyps, as a blanket statement, should be removed. Yeah.
And she hasn't had such a fabulous time at in-rooms procedures. If she's having the cervical polyp removed, what sort of anaesthetic does she have for that?
Depends. If it's got a tiny stalk, you could have nothing. For this person who's had a problem with awake procedures, I'd be looking towards a general anaesthetic, but she might also choose an awake procedure with a local anaesthetic. Yeah, and we do a lot of local anaesthetic procedures in our consulting rooms. The key is to have enough time to be able to put the local in, go and do something else, and come back when it's really had a good chance to work. Yeah. And
for the procedure not to proceed until that person is comfortable.
Yes,
with
exactly. Yeah. And so this sort of thing we don't want to be in a hurry for. So the question about what to do in the subsequent pregnancy if there's been a perineal injury is a really interesting one, because it's one that happens every day, a conversation we have every day, and it's really it is genuinely hard to know how to advise some people, because on the one hand they've had a difficult time with perineal injury. On the other hand, if they have another vaginal birth, on average, they're less likely to get a perineal injury.
Yeah.
So they could theoretically have another vaginal birth with a lower chance of getting that injury in the first place, and that might ultimately be their preference. So one of the things we can do in these situations is is to kind of sort of stratify what we're talking about when we're talking about perineal injury. So third-degree tears are the best example of the severe ones, where the tear's gone right down into the muscle around the anus. It required a surgical repair in theatre followed by a prolonged effort at physiotherapy, and the result was good. So the woman has got normal fecal continence. She can hold in a fart if she's in a lift, and she's pretty happy with that result. We're living in a community here. We want to be fecally continent, and it's such an important outcome of birth to keep our dignity. So we might sometimes say to that woman, look, the data says that third-degree tears need to be expertly repaired, followed by physiotherapy. You've had an excellent result. Do you really want to risk that with another vaginal birth, or should we bypass perineal injury by doing a section? And that person might look at the data for that and think, yeah, section's a better idea. If we look at a much more trivial first-degree tear, where where it was a tiny crack in the vaginal skin that took one stitch because it was bleeding, and that person's also perfectly fine, then we might say, look, I see just way overdoing it for that, and you probably do that well or better next time. And our caller's problem with the granulation tissue needing silver nitrate is really somewhere in the middle, isn't it? Silver nitrate's granulation tissue is a form of abnormal scarring where this red, angry tissue appears in the scar and delays the healing. And we see granulation tissue elsewhere in babies' belly buttons, in the bottom of an ulcer on a elderly person with an ulcer on their ankle, and it responds pretty well to a medication that you can put on called silver nitrate, but it stings. So if there was a fair bit of granulation tissue, the application of a lot of silver nitrate is painful. So the decision has to be made here is what's the best advice. Ultimately, I think our system should allow this to be the patient's decision after giving appropriate evidence-based advice. One thing it's hard for us to quantify as on the doctor end is how distressing all of that was for the patient. So we might be able to say, don't worry, the next birth, you're unlikely to tear anyway, and you're unlikely to get granulation tissue, and even if you did, we would fix it properly under an anaesthetic. But what we can't account for is how distressing the woman found that original experience and just how keen she is on an emotional level for it not to happen again. So all of that needs to be taken into consideration.
Can I ask, the skin that had the granuloma, has that now been compromised? Like, is it more likely that she might tear because of the scarring?
No, I don't think so at all. I think once it's healed, it's healed. And then she would have the standard risk of perineal injury from another vaginal birth, which on average is less than the risk with the first birth.
First birth, yeah.
And so and gets less over subsequent births on average. Yeah.
How common is granulation on an episiotomy?
That's a pretty unusual outcome, to be honest. Yeah. And so, again, before we sign up for a section, with its own attendant risks, benefits, recovery period and so forth, we just have to make sure that isn't worse than the thing we're trying to avoid.
And if she had a birth and it took 3 hours,
so much went well.
Yeah.
Yeah, so much went well.
Yeah.
So this is a tricky grey area. I think that people caring for this woman would be wise to talk about the risks, benefits and likely outcomes, be listening to the obvious distress that's still there, ultimately respecting the decision of the patient how she wants to go forward. Yeah.
I hope that's helped. And Nina, I wanted to say that Nina was our girl's name that we took to. Well, I took to my first 2 births, and Pat and I, that was my girl's name, which we didn't use.
Never required.
Never applied. Good luck with all of that. All right, everyone, thank you so much. I think Dr. Pat needs a little break. You've been talking a lot. And we'll be back next week with another Q&A. If you want to be on a Q&A episode, you just have to go to speakpipe.com. And we have a link in our show notes, so just click that. It's really simple. It's like a press play type of situation. Just have to have your question ready. We love hearing from you, and it just really brings a richness to our podcast that we are very grateful for. So thank you for calling through with your questions.
Thanks for listening, everybody.
All right, have a great week. We'll be back next week. Bye for now. Hey. Even though Dr. Pat is, well, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.